does secretagogue mean? Now you will see in these classes of the anti-diabetic drug, some of these drugs they are secretagogue. That means they secrete the insulin, but some they don't secrete the insulin. So you will see those drugs which are secretagogue in nature, you will have a main adverse effect of the hypoglycemia. Because if they secrete the insulin, then there is a risk of the hypoglycemia also. Okay? So risk of hypoglycemia is more with those agents who are secretagogue in nature. Okay? So this sulfonylurea is also a secretagogue, and then we have two generations, first and the second. In first generation we have short acting drug, intermediate acting drug, and long acting. What I mean to say, short, intermediate and long, depending on the duration of the action. Okay? Then either they are the short acting, intermediate acting, or the long acting. We have an example of short acting, that is tolbutamide, intermediate acting acetohexamide, and then we have a long acting chlorpropamide. Then we have second generation short acting and long acting. We have short acting glipizide, and then we have a long acting glibenclamide, which is a very widely used drug, and we have a glimepiride. Okay? So these are basically the different drugs under the category of the sulfonylurea. Yeah, most of the cases. Okay? Most of the cases nowadays you will see they are most cases they are prescribing the second generation long acting.
What is the change in the second generation?
Improved pharmacokinetics profile. Okay, their mechanism is same, both, but as I mentioned to you that with the passage of time we develop more drugs with an improved pharmacokinetics. For example, we discussed that in second generation glipizide is the short acting, but they improved the pharmacokinetics. Now the other drug, glibenclamide, we have a long acting. Okay, it depends on the patient. Sometimes we have to add the short acting, and sometimes we have to add the long acting anti-diabetic. So this is the sulfonylurea. What is the mechanism of action of sulfonylurea and how these drugs will work? I just discussed with you that these are secretagogue in nature. That means they secrete the insulin. So their main mechanism is release of insulin from the beta cells. This is their main mechanism. Then we have some other mechanism, the reduction of serum glucagon concentration. Again, if there is a reduction, then again the blood sugar level will be controlled. And then also number third is potentiation of the insulin on the target tissue, properly utilized by the target tissue. Okay, so these are the three main mechanisms of the sulfonylurea, that is release of the insulin, reduction of the serum glucagon, and potentiation of the insulin action on the target tissues. Okay, then this is the mechanism. Then sulfonylurea, as I just told you, these are the most widely prescribed drug in the treatment of the diabetes mellitus. The first generation sulfonylurea are not frequently used in the modern management of the diabetes because of their relatively low specificity, delay in time of onset, occasional long duration, and a variety of the side effects. Okay? Then, as we just discussed that these second generation, they replaced basically the first generation in most of the cases. These drugs, if you see the pharmacokinetics, these agents bind to the plasma protein and are metabolized in the liver and excreted by the liver or the kidney, depending upon the drug. Tolbutamide, which is one of the shortest acting first generation, tolbutamide has the shortest duration of action, which is about 6 to 12 hours, and the other agents are effective for approximately 24 hours. So this is about the sulfonylurea. If you see the adverse effect of the sulfonylurea, I just mentioned to you that being a secretagogue in nature, one of the main adverse effects of the sulfonylurea is the hypoglycemia. Okay? So we may have hypoglycemia, hyperinsulinemia because of the secretion of the insulin, and also the weight gain. So elderly patients appears particularly susceptible to the toxicities of these agents. And then we discuss about the first generation, you can see here tolbutamide is associated with 2.5 times more risk increase in cardiovascular mortality. Okay, so this is the reason that why the second generation they replace. In generally we say we have an improved pharmacokinetic profile with the second generation.
I have a question about the oral agents. What is the mechanism of oral agents? I know we take orally, but what is the mechanism?
What do you mean? How these drugs work? All oral agents, or you are talking about sulfonylurea?
They are different.
No, what do you mean? We discussed in pharmacokinetic how these drugs will work.
I know, but I'm talking about the sulfonylurea.
So these drugs, basically, we discussed that when we give the oral drugs, we give the oral drugs when there is some amount of the insulin present. If the beta cell is completely absent, we don't give.
We don't give.
So what we do? Yeah, these drugs, sulfonylurea, they basically stimulate the secretion of the insulin from the beta cells of the pancreas. This is the main mechanism.
Okay.
That's why we discussed that it is a secretagogue in nature. Okay, and because of the secretagogue, we have one of the main adverse effect, that is in hypoglycemia. You know it. Okay. But there are some other actions also apart from that one. So we discussed there is a reduction of the glucagon concentration, and number third was insulin. The was properly used by the tissues. Got to it? Okay. Then number second, we have an insulin sensitizers. Now these drugs, they are not secretagogue in nature, so you will see the risk of hypoglycemia is very low with these kind of the drugs. How these drugs work? We have two classes of oral hypoglycemic. By the way, just mark your attendance now. We are 9:15 now. So I approve this time. Those who are marking the attendance this time, they were considered as a present. So please mark your attendance, everybody. So after sulfonylurea, the second one here we have a glinides, which is also a secretagogue. So what is their main mechanism? Their main mechanism again is to stimulate the secretion of the insulin by the beta cells. Okay, that's why they are also called as secretagogue. What are the examples? We have two main examples: repaglinide, and then we have a netiglinide. These are the two drugs which are included in the glinides category. Both drugs, again, they have hypoglycemia as the most common side effect. Both have a rapid onset and shorter duration compared to the sulfonylurea. Sometimes we can combine the two anti-diabetic agents also. Okay, so this is about the glinide. The third one we have here, insulin sensitizer. Okay, so this drug actually is not secretagogue in nature, so you will see the risk of hypoglycemia is very low. So we have two classes of oral hypoglycemic work. They just work by improving the insulin target cell response. They don't secrete insulin. So we have bigonides. It requires the presence of insulin to be effective, but this bigonide does not promote the insulin secretion. And then we have the second one, we have a thiazolidine-dione, which is also called as glitazone. These are the two categories which work as an insulin sensitizer. Let's discuss about the bigonides first. The very good example of the bigonides, if you go back here, we have metformin. This one, okay? This is a very old anti-diabetic drug, and if you will see the mechanism here, this bigonide previously was used as an anti-diabetic, but because of their mechanisms, they are also nowadays used as a weight reducing agent. So we prefer bigonide or the metformin in those diabetic individuals who are obese. Okay, so apart from that, as I mentioned to you, this bigonide is also used for those patients who are not diabetic but obese. So because we know that obesity is one of the risk factors for the diabetes, so we use this drug to reduce the body weight. So let's see what is the mechanism of these drugs. Bigonides have several biochemical action. Number one is they reduce the hepatic glucose production. So we say it is called as a gluconeogenesis. Genesis means we discussed forming or producing. We discussed in the medical terminology. So they have this phenomenon of gluconeogenesis. Number second, these drugs, they increase the glucose uptake and utilization in the skeletal muscle. So what will happen when glucose is taken by the tissues or the skeletal muscle? The level of the blood glucose will be lower. Number third, they reduce the circulatory low density and very low density lipoprotein. Low density lipoprotein, which is abbreviated as LDL, and very low density abbreviated as VLDL. These are the two, we say they are called as atherogenic. Okay? It's not the term used, it's not here, but just for your knowledge, and it will come in my next topic also. Atherogenic, that means that they are basically increasing the risk of cardiovascular problems. So we say that is called as an atherogenic. Okay? So these LDL and VLDL, they are basically atherogenic. Inshallah, we will see in the lipid-lowering agent that those anti-lipid drugs, their main purpose is to, most of the drugs, their main purpose is to reduce the LDL, which is a low density lipoprotein, which is we say it is a bad cholesterol, and also these drugs will increase the amount of the HDL. Okay? Now there is a formula. Because of that formula, it's opposite. Whenever any patient they have a reduced LDL, so you will see their HDL towards the higher value. Or if they have a reduced HDL, so their LDL towards the higher value. Okay? And LDL we discussed, or VLDL, they are considered as a bad cholesterol. Okay? Since these bicarbonate, they reduce the circulatory low density and very low density lipoprotein, so that's why we can also use as a weight reducing agent. I just mentioned to you that these drugs are considered as a drug of choice in those diabetic patients who are obese. Okay? Then last, their mechanism, that these drugs also reduces the carbohydrate absorption. Okay? We know that carbohydrates mainly coming from the diet. Okay? So when the carbohydrates is not absorbed, the level of the blood glucose will be lower. Okay? Usually what we saw, the most of the diabetic patient, when they eat like hummus, you know hummus, everybody?
Yes.
So they kept the hummus overnight and then they eat it next day. Why? Because during the overnight, that carbohydrates will be removed from the hummus and then they can eat next day. Okay? My mother used to do that.
How do they increase glucose uptake? Without insulin?
These drugs basically, what will happen, that they allow the tissues to take the glucose from the blood.
They have like specific receptors or something?
Yeah. Okay, so they will take the glucose. So what will happen? The level of the blood glucose will be lower. We know that whatever the glucose basically is uptaken by our tissues, but when we use the drug, that uptaken will increase. We just discussed that whenever, if somebody is not eating like 3 days, still patient or people can survive. Why? Because we have some amount of the stored glucose in the form of glycogen. Okay? So what will happen? That glucose will release into the blood. Got it?
So why it requires insulin if it works like it?
Why?
Why does it say it requires the presence of insulin to be effective then?
Because we discussed last time, I think we were absent yesterday. Were absent?
No, I wasn't.
Okay. So we discussed last time that oral agents will never work. All these oral agents will never work when the beta cells are completely absent. Okay? If you have some amount of the beta cells, so those drugs will increase the production. And if the beta cells is completely absent, such as in type 1 diabetes, so the only treatment is you have to give the insulin exogenously from outside. Because now there is no production of the insulin. Okay? Yes, please.
No, you want something.
So these are the mechanisms of the bicarbonate: reduce hepatic glucose production, increase glucose uptake and utilization, reduce LDL and VLDL, and also reduce the carbohydrate absorption. It is the drug of the choice for type 2 patients who are obese. Actually, metformin was the older drug. Previously, when it was used by many patients long time. But nowadays, we say that metformin we use for the obese patient because they will reduce the weight. But metformin is not considered as a secretagogue. We just discussed. It does not promote insulin secretion. So those who are diabetes, who have a diabetes and their blood sugar level is very high, so metformin alone will not work. Because metformin basically, how it works, that whatever the diet you are taking, from that diet the carbohydrate will not be absorbed. You got my point? Okay. So it will not lower your blood sugar level. So whatever the blood sugar, because we know that after diet, after eating, your blood sugar level will be high. So we take the metformin. So after eating, your blood sugar level will be normalized. Okay. So but it does not reduce the blood sugar. Okay. So we say if it does not reduce the blood sugar, the risk of hypoglycemia is very low. We call these kind of the drugs, again it's not written here, but we call this kind of the drugs, they are called as euglycemic. E, U and glycemic. Euglycemic means the true glycemic. Okay? So because we discussed that they inhibit the carbohydrate absorption coming from the diet. Got my mind? This please.
By reduced carbohydrate absorption, they mean the glucose in the bloodstream, right?
Yeah. Because we discussed that in pharmacokinetics also, whatever the drug you are taking, after the absorption, the drug comes into the tissues. Okay. So what will happen? The drug comes in the blood. Okay. So what will happen when the drug is not absorbed? It will not come. We discussed in toxicology also that in case of the toxic doses, our main purpose is to prevent the further absorption of the drug. Because once the drug is absorbed, then it appears in the blood. So similarly here, that once the carbohydrate absorption is reduced, so the amount of the sugar which appears in the blood will be low. You got my point? Okay. So that we discussed that these drugs are called as a euglycemic drug. They only maintain the level of the blood sugar, but they does not reduce since they are not promoting the insulin secretion. Okay. So we see here adverse effect lactic acidosis. Lactic acidosis is too much amount of the accumulation of the lactic acid. Is associated with the metformin use. Hypoglycemia rarely when used alone. Okay. You see the patient, those who are diabetic, they are using metformin in combination with the glibenclamide, which is one of the long-acting second generation sulfonylurea we just discussed. Okay. So glibenclamide is the secretagogue and metformin or biconide is not the secretagogue, so that will be balanced. So hypoglycemia is rare only when used alone. Gastrointestinal disturbances, we have diarrhea and anorexia, and then the long-term use may affect the vitamin B absorption. Okay? Usually those patients who are pre-diabetic, you remember I mentioned to you yesterday that in pre-diabetic we don't give the drugs, we just manage with the non-pharmacological. But sometimes in pre-diabetic also, if it is not managed by the non-pharmacological, we just add this metformin also, only metformin. Got it right? Okay. So this is about the adverse effect. The third one, we have here thiazolidinedione, which is also called as glitazone. Again, these are the example of the insulin sensitizers because we discussed two drugs, biconide and the thiazolidinedione, glitazone. They basically work as an insulin sensitizer. So these agents are insulin sensitizers. They do not promote the insulin secretion from the beta cells, but the insulin is necessary for them to be effective. How these drugs will work? Thiazolidinedione act to decrease the insulin resistance and enhance the insulin action in the target tissues. Okay, by this they can work. Thiazolidinedione activate the receptor which is called as peroxisome proliferator activated receptor gamma. This is the receptor. We have one diagram in the other lecture, so I will explain you about the role of this receptor in that lecture. So these are the mechanism of the thiazolidinedione. We have two drugs in that, pioglitazone and rosiglitazone. These are the two drugs of this group, but most of the countries actually they withdrawn this drug because of their fatal hepatotoxicity. We have cases reported to the death because of the hepatotoxicity from this drug. So most of the countries, they withdrawn, though this drug was actually a very good drug. They have a very good result, but because of the severity of the adverse effect, these drugs are withdrawn from most of the countries. Okay? If you remember, we discussed in the beginning also that we have different phases of the clinical trial. Whenever the new drug comes, we have different phases. One of the phases we have phase 5, which is the post-marketing surveillance. Okay? We have many drugs because of the post-marketing surveillance, they withdrawn from the market. Okay? We have many drugs. For example, yesterday somebody told me about the minoxidil. Okay? Minoxidil was the drug which was very good antihypertensive. Was very good drug, very good result for the treatment of pulmonary hypertension. But the post-marketing surveillance, they showed that this minoxidil has an increased risk of cardiovascular problem. Okay? So what they do, they withdraw the minoxidil, but one of the main adverse effects of the minoxidil was increase in the hair growth. So now you see that these minoxidil, they are not available as an oral, because oral, that means if you are giving the systemic, the severity of the adverse effect is high. They are available as a topical application. Those who have a baldness problem, loss of hair, they are available in the pharmacies. They are using this for increasing the hair growth. You got my point? Because that was an adverse effect of the drug when they were using as an hypertension, that it may increase the hair growth. So minoxidil, then we have many anti-inflammatory drugs that was withdrawn just because of the post-marketing surveillance. They observe this thing, that the severity of the adverse effect in the patient is very high. So these pioglitazone and rosiglitazone, also the two agents from this group. So we have fatal hepatotoxicity has occurred with these agents. Proglitazone was taken off the US market due to this reason. Pioglitazone and rosiglitazone, they can produce the weight gain and fluid retention, which can cause the heart failure and the other cardiovascular problems. And then because of these side effects, I just told you, rosiglitazone, which was available by the brand name of Avindia, has been withdrawn from UK and Europe, and pioglitazone has been withdrawn from some European countries. Okay? Even in our country, this drug is not available. Okay? Because we discussed that this drug was withdrawn. So these are the two drugs here we have. We discussed the insulin sensitizer. We discussed the biguanide and thiazolidinedione. They work by improving the insulin target cell response. Yes, please.
So concerning thiazolidin,
Concerning other?
concerning this company, the whole class is hepatotoxic.
Yeah, because we discussed that some of these are hepatotoxic, and other they are also causing the problem of the fluid retention. Okay, so if the drug has a fluid retention, sometimes what we do, we combine with the diuretic. So diuretic will increase the production of the urine. But as we discussed that this is a fatal hepatotoxicity also with these kind of the agent, so they are withdrawn from the market. So I'm not sure. Maybe I have to check this one. That still this drug is available in some countries or not. But most of the countries, I know my country also, it was withdrawn. You got the point? Yes.
Now, can you go one slide back? Now the names. This is a family or two separate drugs?
Thiazolidinedione is a family, and these are the examples.
Okay, and between the brackets?
This is actually, we also say this also called as glitazone. Thiazolidinedione, also called as glitazone, because their name is pioglitazone and rosiglitazone.
Okay, so this is the name of the family?
This is the class,
Yeah.
and this is the example. If you go back here, in the chart, we discussed that this is the oval are the classes,
Yeah.
and in here, these are the examples.
Okay.
You got my point?
Yeah.
Okay. Yes? You were asking? I think I just explained you the difference is their pharmacokinetics. The improved pharmacokinetics. It's written here also that the first generation sulfonylurea are not frequently used in the modern management because of their relatively low specificity delay in time and occasionally long duration and variety of the side. You got it right? So that's why, this happens not only with this drug, with the other category of the drug. And like for example, if you see in the hypertension, we have older drug, but with the passage of time, they improve the structure. Okay, so when they improve the structure, we say now these drugs have an improved pharmacokinetic profile. For example, there was an antibiotic before, that antibiotic named as a quinolone. So what will happen? The quinolone antibiotic was only used for only 1 or 2 infections. But now they improve, they add the fluorine atom into the structure, because we know fluorine has an antibacterial property. So now the other drugs we have now, which is called as fluoroquinolone. Instead of quinolone, they have an improved antibacterial. So we do this one. In pharmacology, we can call it, I don't want to go in detail, but since you asked the question, in pharmacology, we can call it as SAR activity, structural activity relationship. And when you change the structure, the property of the drug will be changed. Okay? You remember we discussed in phase 2 metabolism, the aspirin, after metabolism, they convert into the salicylate. And this salicylate is still pharmacologically very active, almost equal to aspirin. Okay? But when you, again, after metabolism, the structure is changed, now we have the product glucuronide, which is pharmacologically inactive. Okay? So we say in pharmacologically, structural activity relationship. This people, they are doing the research also, that if you replace this atom with this atom, how these property will be improved. For example, I was working, when I was doing my PhD in 2011, I was working in one of the drug. I was working actually on the animal models of epilepsy. So there was a very famous drug, carbamazepine. Still people, they are using that drug. Now, when I was working, during that time, instead of carbamazepine, they have a new salt which is called as oxcarbazepine. Same mechanism, but with a difference in the structure. So I also worked in the oxcarbazepine, but after a few years, I saw that this oxcarbazepine is not preferred by the doctors. Still they are using the carbamazepine. So how we do? We do this by structural activity relationship. You got my point? Okay? So these are the insulin sensitizer we discussed, the bivonite and the thiazolidine diol. Then we have another class of the drug which is called as alpha glucosidase inhibitor. Okay? The two examples here we have acarbose and miglitol. So acarbose and miglitol, they are basically belong to the alpha glucosidase inhibitor. Alpha glucosidase is one of the enzyme which is present, which increase the absorption of the glucose. So by giving these drugs they basically inhibit alpha glucosidase inhibitor. So how they work? They delay the absorption of the glucose in the gastrointestinal tract. Okay? These alpha glucosidase, they don't have a systemic effect. We say their main function is only to delay the absorption of the glucose. That's why you see the chances of the adverse effect, they are very low. Only we have diarrhea and the flatulence, okay? Because they are not absorbed systemically. So what is their mechanism? They delay the absorption of the glucose in the gastrointestinal tract, which results in lower postprandial blood glucose. Postprandial, we say glucose level after the meal. Okay? Postprandial, we say glucose level after the meal. Okay? So after the meal, when somebody is taking that drug will delay the absorption of the glucose. That's why you see those patients who are using this drug, they take this drug with meals. Okay? So because of the drug, they will delay the absorption of the glucose. These drugs, they do not affect the insulin secretion or action. So we know that if they do not affect the insulin secretion, the risk of the hypoglycemia is very low. Since I mentioned to you that they are not absorbed systemically, so they are very safe drugs. The only adverse effect we have a diarrhea and the flatulence. What is flatulence? Formation of the gases. Okay? Diarrhea, I think you know. Okay, what do you call it in Arabic? Ishal? So we have like side effects, diarrhea and flatulence from these drugs. Then
you said that the patient take it after the meal, right?
I said before meal. Or
Before meal.
Or during meal.
Okay.
So whatever the carbohydrates coming from that one, that will be delayed. Their absorption.
Delay the
will be
absorption,
delayed,
yes.
okay? The next one we have here the incretin mimetic, and this is the last one. We'll stop here. Incretin mimetic. Sorry, just correct this one. In the bracket, this is basically glucagon, not glucose. Glucagon-like peptide.
Oh, alcohol.
Just correct this one. Glucagon-like peptide in the bracket. The next class here we have exenatide or semaglutide or liraglutide. And the class of the drug here we have an incretin mimetic. These are the three drugs: exenatide, semaglutide, and liraglutide. They worked as an incretin mimetic. Okay. Now, what I mean to say incretin, what is incretin? Incretin are the group of the gastrointestinal hormone that increase the amount of the insulin released from the pancreatic cell. This is the role of the incretin. That's a hormone from gastrointestinal tract. They basically release the insulin from the pancreatic beta cells. Now, I just mentioned to you that it's not glucose, it's just a glucagon. I just make a correction on it. Everybody hear that point, right? Yes or no? I'm not hearing the point. Yes or no?
Yes.
Okay. So this is glucagon-like peptide. Incretin are the group of the gastrointestinal hormone that increase the amount of the insulin released from the pancreatic beta cell. So being an incretin mimetic, these drugs, incretin mimetic, not only improve the glucose-dependent insulin secretion. Being an incretin mimetic, these drugs will increase incretin, and further production of the incretin will increase the amount of the insulin released from the beta cell of the pancreas. So these drugs not only improve the glucose-dependent insulin secretion, decrease food intake by control the appetite and the satiety. What I mean to say satiety means the satisfaction. So you will eat little and you feeling full. So definitely when you eat little, so there is a low amount of the blood sugar. Also, these drugs will decrease the postprandial glucagon secretion and decrease the gastric emptying time. Okay? What I mean to say gastric emptying, and it is a time when your gastric contents or the stomach will be empty. So what will happen? They will allow the food to retain in the gastrointestinal tract for a longer period of time. So we say decrease gastric emptying time. So what will happen? You feel satisfied or satiety. So you don't feel hungry, frequently. So these are the incretin mimetic. Incretin mimetic are administered by subcutaneous injection either once daily or once weekly. So there are two, once daily, like we have exenatide and liraglutide, or once weekly, we have an extended release exenatide or a semaglutide. Now you see sometimes we have a, like here we say, in both cases we have exenatide available, but one is the, you see there was mentioned CR and other is without the CR. CR stands for controlled release. Okay, if you remember, I showed you some of the pictures in medication safety also. Okay, so CR stands for the control release. Control release means that this drug is now sufficient for days because that drug will slowly release in the blood. You got my point? Okay, and this actually nowadays, if you see the drug delivery topic, maybe some of you they are interested in drug delivery research. It's one of the hot topic nowadays for the research, that how we deliver the drug safely to the target site. We discussed that, I mentioned to you, insulin. Now the scientists, they are trying to develop insulin as an inhalation. So this is one of the drug delivery, that by inhalation how insulin they use. They use different nanotechnology. Nanotechnology means small particle technology for the purpose of the delivery system. Okay, previously, long years before, we have only oral drugs or the injection, but now we have transdermal patches, and now we have other routes of the administration just because of the oral, because of the nanotechnology. Okay, so they improve the drug delivery system. So this is about the incretin mimetic, by the way, we recently worked in June 2024. We published a paper with the College of the Medicine student. We worked on the liraglutide. We have a co-supervisor from College of Medicine. He is basically an endocrinologist. So we took the patient form, we take the data. If someone is interested in that, you can read that paper. You can just type retinopathy associated with the liraglutide and you will find the full paper. It was published recently in 2024, I think 6 months before. Okay? So it was published in Medicine Journal, which is a very good journal. Okay? So as we discussed that, in this way, we have new things coming from the drug. Got it? So we stop here. How many slides left more? 36, 30. Yeah. So inshallah we will start with the another class. We have DPPI inhibitor next time inshallah. Okay. Yes please. So any questions?